Hey, what's up and welcome to world number 6 of Power Up Endo's 90-day Super GP training program. I hope you learned a lot from that 2-visit lower molar live case demonstration that you just watched. And now I'm going to discuss with you exactly how to perform what I like to call airtight rubber dam isolation. And the reason that I emphasize the word airtight is because I really want you to create a closed system with no saliva influx and therefore no possibility for sodium hypochlorite outflux into the patient's mouth. So I'm going to show you exactly which clamps you're going to be using. I'm going to discuss with you the various types of isolation, and this is only what you need to know. Okay, I try to distill it, as I promised at the beginning of the course, into only what is absolutely clinically relevant. So let's get into it. So first, level 1 of this world number 6, like I mentioned, is all about airtight rubber dam isolation. You see this dam here? That is an airtight seal, all right? You don't want to have any water coming out because it's going to create, obviously, a massive, massive problem, all right? And that's how I want you to think about going about performing your rubber dam isolation on your patients for endo treatment. First and foremost, let's get this out of the way. The AAE has a very strong position statement that states that tooth isolation using the dental dam is the standard of care, full stop. It is integral and essential for any non-surgical endodontic treatment. There's no ambiguity, there's no gray area. Rubber dam usage for non-surgical endodontic treatment is the standard of care. There's no way around it. Okay, and I'm going to show you exactly how I want you to do this. So first and foremost, obviously it minimizes the risk of bacteria getting into what you're attempting to achieve as a sterile operating field. Obviously it's not sterile because it's an open air environment, but it's a very, very clean working environment, and you really want to treat it like it's a microbial culture, okay? Because it kind of is. If you introduce bacteria, whether that be via cross-contamination or whether that be from the patient's bacteria in their saliva, into the root canal system, you're potentially setting yourself for failure regardless of how technically fantastic your root canal treatment is. Additionally, performing single tooth isolation or any rubber dam isolation is going to aid in your visualization, okay? There's a lot of distraction in the patient's mouth, whether that be the cheek, the tongue, saliva, all of that. And being able to block out everything except what you're working on is a huge, huge bonus. Surgeons, medical surgeons do this all the time. They drape a patient and only what they're working on is exposed. And they do that for the same reasons that we go ahead and quote unquote drape our patient's mouth and only expose what we are working on. Also, there have been horror stories, okay, of patients inadvertently ingesting instruments used during endodontic treatment. So there's famous radiographic images of patients who have ingested hand files, aspirated hand files, or some other instruments. There have also been instances of that happening with implant instruments, obviously, right? So that's why they oftentimes will perform a floss ligature on the implant instruments. But nevertheless, you don't even want to get into these potential scenarios. Rubber dam isolation, which is only going to take you a few seconds, is going to solve and eliminate even the 1% chance that anything like that ever happens to you. The bottom line is rubber dam isolation is mandatory. I encourage you to master it, and once you do, it's not even an issue. And I encourage you to appreciate its benefits because honestly, its net benefits far exceed the amount of time that it takes you to do it, which should only be, 3 to 5, maybe 10 seconds. So take your time and just do it and master this skill. There are times when patients are too claustrophobic to receive a rubber dam, and this is an unbelievable minority of the time. Honestly, maybe once every 2 years do I encounter this. Now, if a patient is a little bit claustrophobic and has some anxiety, oftentimes I will tell this patient that the rubber dam is actually beneficial if you're a little bit claustrophobic, because what it does is it prevents any water from getting into the back of your throat or any instruments making their way back into the soft palate or anywhere near their throat. And so it's actually beneficial. And that's true because oftentimes patients will choke up on water. You might have a little bit of saliva that pools back there, and we can manage that. But nevertheless, it's actually something that's more comfortable for a claustrophobic patient. And when you encounter these situations where your patient is very anxious and is concerned that their claustrophobia is not going to allow them to undergo the rubber dam step of the endodontic procedure, then, sometimes we have to sedate these patients. And if you feel comfortable and you are qualified to perform and administer some oral sedation, I would encourage you to do that for these patients. I always administer a very, very light level of sedation, but if you have that in your arsenal and you're qualified and comfortable doing that, that is a very useful tool. Also, you again have the luxury of case selection. So if you don't feel that you want to handle this situation, by all means, do not schedule this patient for endodontic treatment in your schedule and deal with the headaches of situations like this. You can pass this on. It's honestly not worth your time dealing with the potential consequences of a patient who has a really bad experience and blames that on you if it was your fault or not, which it usually isn't, right? And then finally, not every patient is a candidate for endodontic treatment. Sometimes in those rare instances where a patient feels like there's no way they're going to be able to sit through an endodontic procedure, I will tell them, not everyone's a candidate for endo. If you feel that it's not possible, dental extraction is always an alternative, and you're going to have additional visits from that if you decide that you want to restore the space. But, endodontic treatment is a relatively time-involved procedure, and it requires the patient to sit in the chair for, a reasonable amount of time, regardless of how proficient you are. And so you have to take that into consideration, is that not everyone is a candidate for endodontic treatment. Now, in terms of what you're going to use for clamps, okay, keep it simple. You don't have to go crazy outfitting your office with a whole library of rubber dam clamps. 99% of the time, I will use one of these 4 clamps. The molar clamps, which are the 13A and the 12A, and the 13A is for the upper right and the lower left, and the 12A is the opposite. It's for the upper left and the lower right. These are for all the molar teeth that you work on. Then you have a universal premolar clamp, which is the 2T clamp. The 2T clamp fits perfectly for premolars. And then finally, we have our butterfly clamp, which is the 9 or the 9T. The 9T is exactly the same, only it has some serrations, so it can grab a little bit better. But these 4 clamps, honestly, I would recommend that you only get these 4 clamps because, like I mentioned, 99% of the time, these are all you're going to need for isolating a given case. There are situations where you may have to pinch the gingiva in order to get the clamp to hold, and I'll cover that here in just a second. But like I mentioned, this should really be all you need to outfit your practice with. And if you find that single tooth isolation is not feasible, okay, remember, we always have split dam isolation in our tool belt. So I've demoed this for you in the live case demonstrations, and you'll see it a little bit more. But occasionally we will perform a split dam procedure, and what that entails is essentially isolating 3 teeth, where you clamp the tooth distal to the one you're working on, and you swoop the rubber dam material over to the one tooth mesial to the one you're working on, floss it down, and you have a 3-tooth isolation. You're going to see this in demonstration. You've already seen it, and you'll see it again. You will have to punch 2 holes in the rubber dam in order to get the hole large enough. And these holes are overlapping each other, so it creates one big hole. You're going to see this. But the split dam procedure is so powerful because it's really, really great for broken down teeth, crown prepared teeth, teeth that have a lot of interproximal caries, and oftentimes teeth that are not fully erupted. If you find that even with clamping the gingiva, your isolation is not stable, then you can always do the split dam. Granted, you need a distal tooth in order to clamp something distal. So if it's an upper second molar, you can't do a split dam. But it's a great, great tool to have. Also, if you're going to be restoring the tooth with a ring or a Toffelmeyer band, not having the rubber dam clamp on the tooth you're working on enables you to do your restorative work with the rubber dam on. Okay, so it's a really, really powerful tool to have. And also when you're doing caries removal and you foresee that the caries removal is going to be extensive, performing a split dam gives you the room to work so that the burr doesn't hit the rubber dam interproximally and create this startling event for the patient, because it is a startling event. Once that rubber dam hits the burr and spins up into the burr, it requires you to start over with your isolation and all of that. So split dam is a great, great option. Like I mentioned, don't be shy about grabbing the gingival tissues with your clamp if you require that to have stable isolation, where the clamp doesn't rock on you. The patient's going to be fully anesthetized. If they're feeling the clamp, the pressure from the clamping of the gingiva, you haven't anesthetized the patient well enough to undergo the procedure anyway. But don't be shy about grabbing really low on the tooth, and if you have to, extend the clamp itself and grab lower over the gingival tissues. Obviously, I'm not talking about pinching the whole ridge, but grabbing some of that gingival tissue is not going to harm your patient. It's not going to slow down the healing process. It really is, again, a tool that you have in order to have stable, airtight rubber dam isolation. And like I've demoed for you already, and like you'll see further, there's a great, great blockout material out there. There's a few options. I always liked the Ultradent Opal Dam Green product, and you probably use this already for bleaching procedures where you block out the gingival tissues so that you don't burn the gingival tissues. But this material is fantastic, and you essentially squirt it over any exposed soft tissue areas and cure it so that it's a hard set, and it prevents, like I mentioned, sodium hypochlorite from getting in the patient's mouth, and it prevents saliva from getting into the sterile working field that you're trying to set up. Very, very frequently, if not always, used when you do a split dam procedure. And you have to remember that you don't want this to be a crutch. So you want to have really good isolation prior to using the Opal Dam Green, because if you have a pool of saliva, the Opal Dam Green, just like using any composite resin, is not going to hold. It's going to float from the saliva that's coming in. You want to have really good isolation with minimal to no saliva coming in prior to reaching for the Opal Dam Green. We weren't even allowed to use this in residency because our program director, Dr. Safabi, like I mentioned to you, didn't like that potentially it's used as a crutch to not perform great rubber dam isolation without it. And there you have it. That's all there is to rubber dam isolation. There's going to be more that I'm going to be expounding on and really getting into more details, but this is a great overview and it has some really, really useful information, only what you need to know, which is the promise of this course. So I will see you in the next lesson.